Welcome to the Waiting Room Revolution. We're so excited to announce our book, Hope for the Best, Plan for the Rest 7 Keys for Navigating a Life Changing Diagnosis, is available now in paperback, ebook, and audiobook. Get a copy wherever you buy your books, and check out our website, waitingroomrevolution.com, for more information.
This is where I understood that our role as a physician has to be more than prescribing treatments. I think my understanding is if you treat the disease, maybe sometimes you're missing treating the person. But if you treat the person, you cannot miss treating the disease as well. So it's two different concepts. And they're starting slowly to shift to treat the person more than treating the disease.
That was Dr. Christian Ntzimira, founder and executive director of the African Center for Research on End-of-Life Care in Rwanda. Christian introduced palliative care and end-of-life care into health services for Rwandan cancer patients and in the community setting. Today we discuss challenges with providing palliative care in Rwanda, his new book, The Safari Concept, and things we can learn from each other that transcend country and culture. Hi, I'm Xian Xiao.
And I'm Sammy Winemaker. We talk to people who have information and tips on how to unlock a better illness experience.
The Waiting Room Revolution starts right now. So, Christian, welcome to the podcast.
Well, thank you. Thank you for inviting me.
I mean, so you've been described there's been lots of write-ups about you. There's been described as a pioneer of integrating palliative care into healthcare for cancer patients in Rwanda and beyond. What is it like being a palliative care physician in Africa, in Rwanda?
It's a particularly challenging because based on some of the local realities, when we can't get access for basic, let's say, treatment for pain management, especially morphine for those who have severe pain, and also the whole framework for palliative care, the multidisciplinary team, and also integrating the health system. Yeah, we have a lot challenging, but I think everything have been described for so many articles. But I think my understanding and my perspective is to see, despite all those challenges, what is the opportunity, and I think the opportunities to provide palliative care and what is the resources available in the country, and what we can do to have, I can say, the same model of palliative care from my colleagues around the world, but I think to have our own model of palliative care.
Christian, I have a question on behalf of the listeners who may not understand why it's so difficult to get morphine in Rwanda. What are I know this is a big issue, but what are the main barriers?
10 years ago, it was difficult, but now it's accessible. It's accessible because after the genocide against the Tutsi, morphine was not available because, of course, because of policies and also myth behind prescribing morphine. Policies because that is we need to go back, during the colonial period when morphine was totally restricted to be prescribed by local people, and that until recently, when some countries starting to rethink to change the policies, and it's in 2011 when Rwanda became the first African country to adopt a national policy of palliative care. Implementation plan for in the whole system, when morphine now starting to be available in the counter morphine syrup. But before that was a little bit difficult. So this is the part of the policies. And so now we have the myth, and most people, and part of some of our education, people think that morphine hasten deaths. So if you prescribe morphine, patient will die. So, and it's still rooted on some part of, not in Rwanda, but some of African country. I used to travel and see how people are still afraid to prescribe morphine. And and you have myth and you have policies as the most challenged situation in the West African. But in Rwanda, since we have the policy and we are able to push and to describe what is really important for the patient. So before 2011, the quantity was used in the whole country was around 0.2 kilogram of morphine a year. But now we are between 10 and 15 kgs per year, which shows how there is a big change. Of course, the estimation for the whole country is almost 97 kgs of morphine a year. But for the last, I think for the last 10 years, there is a big step have been made. And we hope in the coming years, we have more and more colleagues will prescribe morphine for those who.
I've heard you speak, and you've used this quote before. I want to share with the listeners. It says, "When you are well, you belong to yourself, but when you are sick, you belong to your family." And so, what did you mean by that? Can you expand on that?
I love that quote. I was going to tweet it out when I read it.
This came from my ethnography research in Rwanda, because during my master's program in Boston, which is the program was part of the late Paul Farmer in Boston, global health and social medicine. So I was trying to understand the end of life care on pre and post colonial period, what we gained, what we lost, and how modern medicine could be combined with traditional perspective and perception of care in terms of sustainability. And because during the COVID-19, we had that experiences that when external funding withdraw, care continues. So, and for me, it was really important to understand why, despite all the challenges, care continues. And then during my ethnography research, I just realized that in a Rwandan culture, when there is a disease which can fracture individual society and the community, the role of the community is to come and cover that nudity from the patient. And it came from different saying from my interviews with patient, family members, and part of the community. And then I came up with this, quote, and when it's well described in my my mother language, that when you are well, belong to yourself, but when you are sick, you belong to your family. So it came it represents how the community working together. It's not about the patient in himself, and patient is not isolated from his community, but patient is part of the community. And one side you have the patient autonomy, and other side you have the community responsibility. So it's both in terms of decision making really important on the Rwandan society.
I think that is, every country has its disadvantages and advantages, but that would be a major advantage in my mind, where it is a natural part of the culture, that it is a community event, a responsibility, that when someone is sick, you participate in the care, where here it is almost like for families, it's a disturbance in their occupation, or and we talk a lot about caregiver burnout and caregiver distress, and families don't here the culture isn't that people don't assume one day you're going to be a caregiver, and have to wrap yourself around a loved one. We avoid thinking about these things. It's just not this idea of community responsibility to a sick person is not as prevalent as Rwanda. So I think that's a beautiful thing about the culture in Rwanda.
Yeah, I think it's a part of the last year when I was in McGill, and when I discussed with Bernard Lapointe, it is more about exchange experiences. I think we need to learn from each other. And I've learned on my experiences under my education. Most part of palliative education, I got it from US, and I've learned a lot. And I've learned a lot from US. But the idea here is to share with my colleague from US and Europe and everywhere to say, I've learned, as we learn from you, would you mind also learning from us? Because we need to create that platform where we can change. As you said, there is advantage and disadvantage everywhere, but let's learn from best practice. And that is, I think, on my understanding, is really important in terms of how we can involve human resources, community. It's something which was my first trip in the US it was a shock. I was doing kind of fellowship observership in Massachusetts General Hospital, shadowing my mentor, Eric Krakow. And as we spent a lot of time, so it was my first time in a US hospital, and we went to the room, and I saw the room was so big and fancy. And I was joking, like, Eric, I can live here with my whole family. So the big room. Like, you have a TV and everything so far. I was like, wow, how can patient can live with this kind of room? But the shock for me was to see the patient was alone and surrounded by pictures, old type of pictures, black and white and colored pictures. And I was asking my supervisor and say, where are they? Because I can saw the patient in the pictures was happy and surrounded by so many people. And I was like, where are they now? Of course, he told me that, the context in the US, you have people live in West Coast, and sometimes it's kind of difficult. But I told Eric, I'm sorry if I don't understand, but try to explain to me, because from East Coast to West Coast, every hour you have a flight from different airlines, Southwest, Delta, you have Jet. So how can you explain to me that someone in the picture cannot just travel for the last days and hours? Especially in the US, you have a matrix to measure the dying person and understand that just in terms of hours to days, this person may go. So why that person cannot travel? Because in Africa, and I was trying to just tell him that in our context in Rwanda, we don't have picture in the hospital because people are there. It's full of people. And when when the family members live abroad, they try to travel and stay at least for the few days or weeks with the patient because they are connecting to them. So I'll try to explain to him it's a matter of what we can learn from other cultures, what we can learn from other side of the law. And it's not because we don't have access to morphine or the level we want, that means we don't practice palliative care. That is, of course, a challenge, but also we have something we can share.
Yeah, it's such an interesting observation coming from a completely different culture, that would be something that was so striking to you. I think the other reason why people put pictures in the hospital rooms is because families want, or the person wants to be seen as a person. And I'm not just someone in a bed with cancer or labeled palliative, that I actually have had a life and there's people in my life. So, but I hear what you're saying. It's striking that the people aren't there. Yeah, because for lots of reasons. And I don't think it's just because travel's, the distance between the East and the West Coast, like you said. It's not a given. It's not part of the ethos of the culture is to, drop everything and be around someone. And there's a beautiful, there's so much that families can and do for their loved ones, so much more than really the healthcare system. They fill all the hours in between. And Sian and I talk a lot about that in our podcast, that the family is part of the unit of care. And the spotlight has to be not just on the patient, but the family. You're all going through this.
Exactly. And this, it's what I described in the book I just published called the safari concept. And the safari means journey. It's nothing with animals. I think when I mentioned that, people are laughing because it's nothing with animals. It just means journey in Swahili and just moving from one place to another. And in the book I was explaining, one of the approach I'm using is, I call it the butterfly approach, as I said, because one end you have on the left wing, you have the patient's autonomy, expectation, privacy, everything from the patient. In other end, you in the right wing, you have the community responsibility based on resources, norms, culture, and everything. And this is where I understood that our role as a physician has to be more than prescribing treatments. I think my understanding is, if you treat the disease, maybe sometimes you're missing treating the person. But if you treat the person, you cannot miss treating the disease as well. So it's two different concepts. So, and I'm starting slowly to shift to treat the person more than treating the disease. Sometimes we are so focused on lab tests, everything, treatment, how we can adjust, access to blah, 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 and everything. We have a bunch exams. And then at the end of the day, I'm sharing from my personal experiences when I failed many times to treat the person because I was so narrowed focused on the disease. Then I just realized it's something wrong. Then how can I adjust that? And one of the idea was to bring the families and the community. But in Rwanda, if you call a family meeting, how many people do you expect?
You're setting us up. Okay, I'm just gonna go for it. 5.
This is the minimum, because it could go from 5 to 40. The last meeting I have 40 people in the room.
40.
My role is not to define who has to be part of the meeting. Is they to define what they call family. And they know exactly who has to be part of the meeting. Sometimes they come 10, 20, 30 people. And the last meeting I had was 40 people I came. So it's not the number of people in the room, it's the number of suffering in the room. And it's only one. It's one suffering shared by the community to see the loved one who is dying. So if you focus on the number of people in the room, of course, you'll be, your reaction could be a little bit challenging for the families. Yeah, exactly. Yeah,
intimidated.
Intimidated, yeah, because you say, oh no, guys, I will not talk with you. And if already the disease fracture individual, society, and the community, and you bring that you cannot talk to them, and you will talk just for few people, so then you are part of the challenge. You'll fraction more the disease. And that's for the family, you'll increase their suffering and will not release, and they will be more depressed. And that's why I came with the idea, let's invite the family meeting. It's my role is to reconcile the patient and the community. So my role is to reconcile what was fragmented, what was fractured by the disease. So I see my role more than that. My role is not just prescribing, because any pharmacist can do what if it's kind of medication. But I think physician, what's expecting from the patient and family members is sometimes to bridge the fractures, to bridge the gaps brought by the disease. And then to bring them together, to reconcile, the role of reconciliation between the patient and the family members. So when they come in the room, usually I'm asking 5 questions. And from those 5 questions, my role is to identify 2 things. One, who is the lion or the lioness in the room? There is always a dynamic hierarchy in the family, depending which social events. If it's a wedding, it's totally different from the funeral, which is totally different for the disease. And I need to identify who is the lion or the lioness. So, and the second point is to identify which kind of suffering expressed by the family members through different behaviors. And then from there, if I have those 2 elements, I can be able to support. So you can be 100, they can be 100, they can be 200. It doesn't matter the number of people, just the number of suffering in the room.
What did you mean by the 2 kinds of suffering? Can you just, I missed that second point. The second thing is, you said there's 2 kinds of suffering, or how many people are suffering? What did you mean? Sorry.
No, when I mean suffering, it's what kind of suffering expressed by the family. Let me give you, in my book, I give so many examples. So I'm using animal metaphor, animal archetype to describe a certain behavior came from the suffering. Let's say, for example, what I call the giraffe suffering. The giraffe suffering is a suffering expressed by family members when they came with unrealistic and unattended, expectation. When they want, maybe, most of our patients are in district hospital. They come at the district hospital and they want the MRI, they want to see an oncologist, they want to see blah, 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 they want to see. And it's most of family members who live abroad from US, Canada, and Australia, when they travel back and they just want the patient, in a district hospital, and especially in low and middle income countries, how do you expect to have an MRI or CT scan or an oncologist? We are just lucky sometimes when you find the general practitioners, but if you find a specialist, you are more lucky. But how do you expect to have those bunches? And for us, this interpretation is just a suffering. There is a suffering of mistrust of the local resources, local people. And that is really important. Instead of blaming the family that, oh, you are challenging, you don't understand, blah, blah, blah. We understood this is kind of a suffering. And our best management is confidence with humility. That is the way we respond to them, because it's a suffering. We don't take, it personally. We don't judge them because they're suffering. Another example is the hyena suffering. Hyena suffering is the suffering expressed by family members when you saw so many conflicts between brothers, sisters, parents, cousins, uncle, aunties. The disease brought up a strong conflict who was hiding from the family for many, many years. And for us, this kind of suffering is expressed. The meaning is the patient is a source of conflict, but also the source of connection. So the family has been in conflict for so many times, maybe came up from the patient. And now, by feeling that the patient is going to die, and that gaps of an opportunity of reconciliation, it doesn't work for them, because they've been in conflict for so many years, and it's now a part of their life, and they cannot, leave them. So they need to keep on that, comfort zone, and the conflict is a comfort zone for them. So then the way we respond, one is to identify who is the most influential person in the group, And second, we don't have the meeting with all the family at the same time. So we try to divide based on the identification on the solution. And third, we are using sometimes legal perspective.
So, Christian, you're using animal safari metaphors to describe suffering and then how we as healthcare providers can respond. And you've told us about giraffe and hyena suffering. Is there another one you could share with us?
The tortures. Tortures suffering is the suffering expressed by family members when they came with a very, strong shield of religious and belief, traditional, strong philosophy about cure. You can say anything, they will not understand because they strongly believe that the patient will cure. And we understood that the meaning of that kind of suffering is there is unaccomplished or unfinished work. Maybe the patient was starting to build a house, he get promoted at the job, is going to be graduated from a school, and or the patient just got a green card to move in US or in Canada. So that unfinished work is difficult for family to understand because that is suffering from them. There is no, we cannot know because there is so many things the patient has to do for us. And for us, the management of this kind of suffering is language matters. So let's say, for example, if there are Christian families, when I'm getting in the room, I remove my lab white coat and my stethoscope. I just come with a normal clothes, and I'm sitting there among them, and I say, "Praise God," or "Glory to glory to God," or something, because. And then if they are Muslim family, and say Salam Alaikum. And if I'm prescribing, I say, let's see, Inshallah, Alhamdulillah, we hope that everything will be okay. If it's a tradition, I'm using also traditional vocabularies and everything, because that will not remove my physician, status or everything, but just put myself on the language they can understand. Because if you use the language, then you'll melt the shield and you'll be able to be part of them. So in the book, I describe 12 animal archetype, which is 12 meaning of suffering and 12 language and 12 solutions.
Wow. Yeah, the book is called The Safari Concept, an African Framework for End-of-Life Care, and it's available now. And our listeners, and we're going to get it. And I love the metaphors because that's what we found was so important for the waiting room revolution.
So much of what you're saying, like I'm just nodding my head. People can't see because it resonates so much with my experience as well. I have always worked in people's homes, and it's not part of medical training. It's not a mandatory part of medical training. So people get trained basically in clinics or in hospitals. And so the role and their view of the family is very different than my view providing home-based palliative care. I have the utmost respect for when you enter into someone's home, you are on their turf, their property, and in their home, their culture. And I'm like you, Christian, I never show up with a white coat or a stethoscope around my neck. I am just a human who happens to be a physician. And I too approach the care in a very human, just very plain language, very comfortable environment. And that has afforded me to do much more satisfying work with patients and families than if I was walking around just talking Latin and Greek and medical terms all the time. And so many of our physician colleagues feel helpless at a certain point in the illness journey because they do not know how to lean in the same way that we do. When you can no longer fix something or cure something or have another treatment or a test for something, they don't know what to offer. And we are the best therapeutic intervention, as a human with experience and knowledge, helping to reconcile all of these different types, not reconcile, but reconcile some of the problems that have created the disconnects that we see. The power differential between the doctor knows everything, but the patient and the family, don't know as much as the doctor, or, that the patient gets all the focus, but the family's in the shadows. Like, there are so many things to reconcile. I think you're right. I think our main role as palliative care physicians is to attend and identify suffering, different types of suffering, but also, like you said, to reconcile so many issues that have created an illness journey that has been derailed and contributed to suffering.
Yeah, exactly. I know you articulate it very well. The disease, brought different disconnection. Even the patient is disconnected with humanity and disconnected to his role, or a role in the society. And and it's why I'm thinking that our role is more than that. It's more than prescribing, is to have this kind of reconciliation, because that will bring also an harmony between the patient and the environment. And it's, as I said, it's not the number of participants in the room, it's just the number of suffering, and almost just one suffering expressed on different behaviors. And if you understand the language of suffering, and it's so it's easy when I think using the safari concept, because when I discuss with my colleague and say, you know what, I just came from a meeting and we had hyena suffering, it's 1 second. They understand. They understand the challenge. They understand this, and they understand the challenge. They understand the meaning, and they understand also the solution. It's why local context matters. And I totally understand, the context in US and Europe about the patient autonomy. And but I understand also there is opportunity from all of us to create, if we need to create a global palliative care community, we need first to connect at a local level, because global is local. And there is, we cannot connect a community without connecting identities. And that is something really important. So different contexts, different perspective, but how we can learn from each other. How, when I'm traveling, I'm going to come in Canada in October, spending time with Gary Roden at Princess Margaret on Quebec for almost a month. And I will be there to learn from Canadian perspective, to learn also from the challenges, and also have an opportunity also to share from us. So everyone will pick up from what is I can learn from this culture, what is really important. And that's, if we focus on that, I'm pretty sure the next palliative care generation will release, I think, most of suffering we have now. Maybe we'll find that different challenges, but at least at this level, something will be changed. And I'm hoping for that.
But there's another saying that I want to just unpack a bit with that you've talked about, is decolonizing palliative care. And I think, in North America, we don't really think about that as much, but what do you mean by that? Like, why is it so important? And what does that look like from your perspective?
I think it's recently, I think before COVID, there was a movement to try to standardize, palliative care as one palliative care need to be, some indicators, the matrix has to be used everywhere in the world. And I remember I was part of some of the discussion, and this was really challenging to me, because I say you can't put everybody on the same standard, because we don't have the same norms and even understanding. Even the perception of care is totally different from one setting to another, because death and dying is so connected and related to the identity of the person. just putting one standard palliative care for everybody, my understanding is that will be that will affect, our practice. That will impact our practice. And based on my experiences, when I failed many times when I was in Boston, trying to duplicate the model from Boston in Kigali, and I've been conflicting with the patient, my colleagues, and the environment. That's why I came that maybe we need to decolonize end of life, because practice can change because local contexts change, and we need a different models. But if we understood what can I say, the rich culture we have from different perspective, I think we can create something beautiful I cannot find in internal medicine, in surgery and pediatry. We will create that sense of not only any sense of humanity, but we'll create a strong, let's say, platform and approach when everybody, physician, family carers, and the patient will find themselves a role to play instead of to be a consumers or a clients or a providers, because we'll be navigating on that approach. So it was kind of to remind all of us that we need a different perspective. It's not what works in Rwanda must works in Canada, and what works in Canada should not be imposed to other settings, because they have a way of thinking, they have a different of perception, and that also has to be taken into account. This is why I'm saying we need to decolonizing end of life care. What will be the lesson, and what will be also the opportunities, and that was my approach, and that's yeah.
It's interesting because there are so many common elements, though, that you're talking about that I completely relate to in the work here in Canada. So I feel like although so many communities and countries have different culture, and we must pay attention and allow that to influence us, I also think that there are some common threads. This idea of humanized care, the ideas of suffering, the ideas of family and community. When you think about it, that those things would probably cross different countries. It would unify, but the approach has to look at those things, not some other rigid structure for palliative care. It's more the things we're talking about that should be the common elements, in palliative care in any country. The role of the community, the family, the person seen as a human, the doctor seen as not almighty and all-knowing. And, these are the communication, these are the common elements of palliative care.
Yeah, exactly. And because I had the opportunity to travel on different places, and I've learned a lot. And unfortunately, we have still challenging from my colleague from Western country to come and learn from us. And I remember that was a long time ago in 2014. I remember I was just in the beginning of my palliative care professional career. And that time, Professor Bernard Lapointe was, he gave some scholarship from people from low income country to come and present about the work. And I remember in Montreal, we have a session from low income countries, and I was that time, presenting that we don't have access to morphine enough, and it was very. It was an early beginning program, starting in the country, and the part of the participant, one participant, just said, "Christian, what you are doing is not palliative care," and I was shocked. I was shocked, Of course, I didn't expect that people will say, wow, you're doing a good job. But to say that everything we did, all the limited resources available in the country, all the training we had with the team, the multidisciplinary team we set, starting to talking with the patients, and even using codeine as a second step for those, even morphine was not full available in the country. But all those efforts for him was like, no, this is not palliative care at all. You can call it something else, but it's not palliative care. Then for me, it was like, this was the shock of my life. And because I was so happy and enthusiastic, presenting, our small, effort to relieve suffering from family members, and someone just came and slapped you in the face that this is not, and like, it was kind of discouraging, but also another sense was also encouraging to say, maybe we need to continue in that way. Maybe they don't understand our setting, they don't understand maybe the local context, they don't understand our social perspective, and it's pushing me more and more. Say some people can be biased because they don't have enough information. But if they have enough information, maybe their perspective may change. So let's still give hope, and let's still open windows and create a platform of mutual exchanging program instead of to be biased. Yeah.
I still think we're training people sort of like that person in Montreal, where there's a very narrow definition of palliative care and what the role of a palliative care doctor. And so sometimes my biggest fear is that amongst my own palliative care colleagues, we don't have an appreciation for some of these broader ideas about palliative care. Have you thought about what you wish you had said to that person?
No, I think I was just shocked. I didn't say anything because how can I respond? Because he never been in Rwanda, and I totally understand. But if you grow up on that framework, and you get this kind of teaching that maybe you are the best, you have access to not only to morphine, oxycodone, hydromorphone, and the fentanyl patch, and all those stuff, and you have the guy who just say, when someone is severe pain, I'm trying to give to combine maybe I don't know, acetaminophen, paracetamol, and codeine, sometimes tramadol, with so many side effects, but with what was available, and the guy say, no, this is
Do
not
you
palliative.
think that's what he meant? He meant that's not palliative care, because palliative care is medicine. It includes medicines, and I think if I was going to respond to him, I would have said, so how do you define palliative care?
I think that time I was young, so
yeah, I always, when these things happen to me, I spend hours thinking, what should I have said? I wish I could have said something, but you're not the same as me. You're a very peaceful, calm, you learn and you move on. And I
think also that time I was young, and maybe not enough experiences on like now, but
you feel intimidated when you have a comment
I feel
like
intimidated
that.
because it was my first conference in Canada, and I think it was even my first conference out of Kigali, and so.
But all you've done since then is go deeper and deeper and deeper into this work. And I am eating up everything you're saying. I love it. I relate to it completely.
But do you ever imagine a world where the target audience for these 12 archetypes aren't clinicians, but could be the public? Whereas, maybe somebody in the family, maybe some patients are very self-aware, could identify the kind of suffering that they might be having or might be likely to have, and therefore say, this is the kind of suffering I think we might present. This is what I think we need to move forward the best. Could you, when you wrote that, was your target audience of clinicians, and could you imagine a world where it was patients and families?
So actually, during my journey, it's why I'm saying suffering is journey. and it's a journey of three kind of people: one for the physician, one for the patient, and the family caregivers. So I had the chance to, when it was a manuscript, to give it on those three people. One, I get a chance to get feedback from the patient. I get the feedback from family members, those who have patient and those their patient passed away, and also from my colleague physician, and all of them will say this kind of this book was really helpful because I was expressing something they cannot express by themselves, from the patient, from the family members, and especially from my colleagues, because you say you articulate it very well, this kind of suffering, and I was using simple words without any medical jargon, and everyone can get access on it. And because I believe my best statement is the way people die can reflect how the society lives. So if we need a better society, we need also to understand, to focus on how our patient died, and the learning from them is something really important, not only in terms of metrics, because we have now so many things and most information, but still suffering is something that need to be addressed, and that's depending from one society to another. But having that experiences for together, I think it should be something really important. Yes, the book is accessible to everyone, not only for physicians, because everyone has his own journey. I have my journey as a physician, which is totally different from the perspective of the patients and also the family members. But how to reconcile the both, for me, was just that journey was really focused on this book.
You picked up on themes. There were themes over and over, patterns and trends, and you observed that, and then you could capture it in your safari animals.
Yeah, exactly. Because when I have people sitting, 40, 30 people in the room, I'm not intimidated by the number. I'm not intimidated by the position. I know exactly which question I'm going to ask, and I will poke the beer. I will poke the and the lion will come up. Either it could be elder person or elder woman, or one of the rich person in the family, or the most educated person. So it's very dynamic depending on the circumstance. Because we have our normal hierarchy, which is we have the patriarchal or the matriarchal in the family, but depending from the social event, depending from different circumstances, the role of the lion can move from one person to another. And that was something really important to understand, which was kind of obvious in our family when people resolve conflict. But if I was not pushed by my colleague from US to write about this book and to publish about what we are doing, maybe I will just keeping it for me. So this is why I'm saying we need this kind of collaboration to value the expertise by experiences from local people.
I feel like there is something that unifies us as a human race. And so, maybe language matters, culture definitely matters. And I think it is about recognizing expertise, but culture should influence the way it is implemented and the way it's meaning. And so culture has a huge role to play, but I don't know if it's only science and measurement and randomized trials that are going to elucidate culture. In fact, I think cultural influence is probably at a higher level than just sort of knowledge, because knowledge is just fact, but culture is meaning, interpretation. But I did wonder if at the end of it, the ways that you approach these conversations are really fundamentally the same as the way Sammy would. I don't know. I guess I'll read your book and find out. But what is your sense, having seen these happen in all over the world?
I think I'm a very positive guy. I think I'm hoping. I think the experiences come from the genocides against the Tutsi in 1994, when we lost 1 million people in 100 days. But humanity itself seems lost that time. And I strongly believe that the concept of palliative care will also contribute to bring back the sense of humanity we lost during the genocide, because palliative care is not only about withdrawing or withholding medication. It's also about dignity, humanity, and Ubuntu. So as I said, let's say, for example, by inviting me for this podcast, I think you have a bunch and bunch of speakers around the world, and by collecting all those stories, putting on the platform so each one can learn from others, this is, I mean, a Ubuntu philosophy. This is why you reconcile from different perspectives, and this can give me also a sense of hope that I'm not alone in this, journey. So in our journey, we can have also a different person from different country who's thinking like me, who's thinking that maybe we can work together. It's not about, oh, I'm the best, I'm the one who's doing everything. It's about we, because it's about all of us. And as we said, culture is very strong. It's very strong on our identity. And I saw that even when I'm traveling in the US and Canada, and so Rwandan families, they're still, even if they're working in the US and Canada, but they still keep their culture on very simple thing.
Yeah.
And that was something really important.
Ubuntu means we live through other people. It means we, right? Society is a we.
Yes, it's not about I, it's totally different from the Cartesian philosophy. I think, therefore I am. Ubuntu is about I am because we are.
Yes, that's it.
It's a humanity toward others. So because we don't define as I, we define as we. And when I'm admit my patient, I will never say your patient or the patient. I'm always say we, our patients.
Yeah.
Our patient is suffering this one. Our patient need this, and our patient need that. So by changing that, the family feel included, and they also include me in the cycle. And just to finish, last year I lost my brother. It was a very painful situation because I wasn't in the country, and they told me that he just passed away. Then I came back, when I traveled back home, and seeing, those all the community came at home. Every day is almost 200 and 300 people every day.
Wow.
They were there from morning to evening. And then during the funeral was almost, if I'm not mistaken, around 1,000 and 2,000 people. Because for us, the funeral it's a social event. So the more you have the community, I was seeing, old friends, people we didn't see each other for a long time. There was already there every time, the time of, the grief and bereavement process from the family was kind of shared to the whole community, which relieved, yourself and the family was well absorbed than feeling alone, sitting yourself and thinking about why he died, and I'm the physician, in the family. I'm supposed to be there. Why didn't all those why starting to disappear, and I feel myself connected with the community. I feel myself part of the community, and they were with us during the 7 days, and then we have the funeral, and thousands of people coming and talking about his accomplishment, and just realize death is an accomplishment, and and that was really part of to relieve the suffering and move forward in that sense.
Christian, I really want to thank you for being so vulnerable and inspiring.
Thank you for inviting me.
Thank you.
Thank you, Christian.
Thanks for listening. Don't forget to rate, review, and subscribe if you haven't already. You can visit our website, waitingroomrevolution.com, to learn more about our movement and how you can join it. The podcast is produced by myself, Kayla McMillan, Valerie Bishop, Shilpa Jyothi Kumar, and Maggie Sivak. Our theme music is Maypole by Ketsa.